Thank you, sir, for a wonderful introduction. I'm Dr. Shankar Balakrishnan. I'm the most odd out here. I'm an interventional neurologist. So I got a passion towards neuromodulation because neuromodulation is the language of the brain, and how we are going to use this neuromodulation to improve the quality of life in patients with spinal cord injury. When we talk about spinal cord injury, what is most important is the disconnection of the supraspinal signals to the locomotor system that is existing below level. But the truth is, even though the signals are not able to reach the locomotor circuit below the level of injury, can act independently without any support from those things. It's just like a newborn who is doing a stepping reflex or the reflex arc. The locomotor circuitry in the spinal cord is sufficient enough to bring a walking movement or walking like movement. And we look out, when we select the patients, what is most important is the length of myelomelastic changes, the degree of spinal cord injury, the atrophic spinal segment, and the residual nerve conduction. Only the two criteria. Look at the nerve conductions report and the MRI, look for residual supraspinal connectivity fibers. So there are methods to find out the residual supraspinal connectivity. And when we talk about the mechanism of action, when you put an electrode on the surface of the spinal cord and when we stimulate it, the current doesn't penetrate into the spinal cord, but instead it flows along the surface of the spinal cord to reach the myelinated fibers. And from the myelinated fibers, it enters into the spinal cord to activate the anterior horn cells. So it makes the anterior horn cells sensitized. Even a trivial signal from the brain is sufficient enough to trigger the locomotor circuit in the spinal cord itself. And this mechanism has been proven with a lot of calcium release PET scans and through the hotspots. Whenever the signal enters, they map the spinal cord to make what are the neurons that are necessary to activate the locomotor systems in the lower limbs. So this is possible, and a lot of studies are coming up and a lot of evidence are also coming up, and the West is doing with approved trials. And the question is now, can we do it in India without all these advanced methods and modalities to map the spinal cord and what our devices that we got? So we named it as STIMO, Stimulation Movement Over Ground. Here, when we choose the patients, there are certain criteria. Currently, we are limiting ourselves. The patient should be young enough to cooperate for the post-neuro rehabilitation. Also, we look at the spinal cord atrophy and also the age of injury. Age of injury as of now is not a major hindrance for us. Only if there is very severely atrophied cord and a long myelomelastic changes and any lesions which is in the chorda conus, we don't take them up. So elderly, above 60s, we are not recruiting, and we are choosing young people like 30s and 40s who can cooperate for who can cooperate for the neuro rehabilitation. So what we are looking at here is during the surgery, here is where the neuromodulation specialist, the neurologist, and the spine team work together. There are multiple ways to put the paddle lead inside. The location is T11 to T12. In MRI, we have to look at the chorda conus, and we need to place the electrode exactly over the chorda conus. That's all the task is. So this covers entire roots. There are some do complete laminotomy, put the paddle lead on the surface, but what I would recommend is do a small laminotomy, a small hole, put the sleeve inside, create a tunnel, and put the leads inside it. So this will help in holding. This is natural. We are not doing many distraction there. So simple laminotomy, put the electrodes, check for the median position, and intraoperatively, we do electrophysiology also to confirm the right and the left, whether there is an equal stimulation on both the sides. So when we do this, we have confirmed that under the fluoroscopy, we can confirm the midline position, although it is anatomical. Physiological midline, we don't know. So we do intraop monitoring also. So in intraop monitoring, before positioning the patient itself, all the muscles like vastus medialis, vastus lateralis, and gastrocnemius, soleus, tibialis anterioris, we put the electrodes so that we can get the stimulations. Once we put the paddle lead inside, we connect to an external stimulator to stimulate and look for the EMG activities in these muscles. So Whenever we get this movements inside, there will be a stepping-like movement happening on the table itself. So we need to tell the anesthetist not to paralyze the leg because we need real movements there. So when we look at the movements of the leg, the EMG also will correspond, and then we will get this continuous pattern of waves coming up from each muscles. This ensures not only that the epidural is working, but also helps in mapping of the spinal cord in the later phase. So all the vital muscles should be, we should not forget to position the patient, because once you position and started, then it becomes very difficult to locate all these muscles and put the electrodes again. There are different types of electrodes available, but for most, the small needle EMG that we use for intraop monitoring is sufficient, and the intraop machines that we got to do the routine spinal surgery is sufficient enough to do the intraoperative neuromonitoring and also to map the spinal cord. So it will give an idea how much rostral and how much caudal we can push and pull the electrodes. So once we secure the electrodes, we close, and then we give a healing time of around 1 month for the electrode to get fixed on the surface of the spinal cord. So when we start rehabilitating and when we start mapping, what is foremost important is the autonomic, means the dysautonomia with the spinal cord injury. When we stimulate the cords, the patient will have a drastic postural instability and fall in blood pressure. So initial first 7 days is a protocol to stabilize the hemodynamic stability. So what we do is we do the rostral mapping. So the cords, the electrode has got a 5-6-5 system, a rostral and a caudal portion. So when we manipulate and then do settings on the rostral side, within 7 days, with the help of a tilting table, gradually we elevate and bring it up to 70 degrees. So whenever there is no fall in blood pressure for the 70, even at 70 degrees, then the patient is good enough to go with the mapping systems. So initially, we do a mapping in the lying posture. So what is important in the lying posture is the hemodynamic will not be so severe, so the patients can tolerate the lying position mapping. And when we do the mapping in the lying posture, what is most important is to bring out the anti-gravity movements. So what we look at is the pelvic muscles floor exercise. This is the mapping electrode. Here, we are looking at the spatiotemporal, how the electrodes and the nucleus inside the spinal cords are mapping up. So when we stimulate the rostral, we will be able to get movements of the proximal muscles, and when we work on the caudal, we will be able to stimulate the gastrocnemius and the soleus. So this is the mapping methods, because million of combinations is needed to explore the leg movements. But when we do a mapping with a spatiotemporal, it's easy to get the movements in the proximal as well as in the lower limbs. So when we do the proximal movements in the lying posture,
Last
patient
few
will,
slides, please, Doc.
yeah. So the patients will be able to get confidence to move the proximal leg movements initially, and later on they will be able to do the extension, flexion and extension in the lined up, as well as the anti-gravity movements will also be possible. Next is mapping in the sitting posture. So mapping in the sitting posture, also this is the most difficult part of the mapping, where we try to bring the leg extension movements. So the leg extension is very difficult to get, because extension happens at a lower frequency of 25. So when we increase the frequency above 25, it becomes very difficult to get the leg extension movements in the sitting posture. So this needs around 2 to 3 weeks to map the leg extension and to get the exact settings. So each patient will have a different settings to make them walk. So initially they will not be able to walk independently, because the truncal control will be very poor with them. So what we use is a weight suspended great trainers to make them walk. And when we put them on the treadmill, we need a weight suspended gait trainer, and the treadmill, the movements of the treadmill will initiate the stepping reflex along with the stimulation parameters that we give. So initial 1 month, they will be trained on the treadmill to bring walking movements. Initially, the therapist should assist the leg movements. Later on, when we know the mapping of the gait cycle, they will be able to walk without assistance from the physician or the physiotherapist. So here they will locate the proximal muscles and they will map for the gait cycles, and each mapping is it's very difficult to get the walking settings. Patients will need multiple programs. Anatomical representations will be difficult from the representation than the graphics. Here the chord roots are stuck, so we need to get a real spatial orientation to stimulate and to bring the mapping walking movements. Once we map, and then the patients will be able to step on their own without the stimulation also in a later period. So when we give stimulations, initially the therapist will be assisting. Slowly the patient will move their legs on their own on the treadmill to make the walking movements becoming possible by the end of 1 month. So we are able to make them walk on the treadmill with a weight suspended gait trainer. There are a lot of limitations with this procedure. The most common is for quadriplegia, we cannot put an electrode on the cervical as well as on the lower dorsal. So we need new electrodes to come up. In these new electrodes, what is most important is we need a larger electrodes to cover the trunk also, as well as some to cover the cervical. There are new batteries going to come, and there are new prosthetics also going to come. Onward is a new battery that they are planning exclusively for the paraplegics to walk, which can control the arm function, hand function, the blood pressure control, mobility, as well as the bladder and the bowel control. So when this comes, there will be definitely future, this modality is going to help a lot. And mapping of the spinal cord, the anterior horn cell, which are the cells that are specific to bring the walking movements, is also mapped. This article got published in 9th of November, so we know now what are the cells that we need to target also. So this modality gives a lot of information to make this procedure more refined in the future. And when we ask about when the patients ask whether I can walk, what we are promising is definitely the quality of life is going to improve it. And this modality is there are a lot of new potentials associated with this procedure. And this is one of the patients who worked for Army. And we are doing this procedure only for those who got funds to support this procedure. And we run this program that the patient stays with us for 6 months until they become ambulant and they are ready to walk at the home. So whatever be the level of injury, whatever be the grade of paraplegia, what is more important is to make the quality of life better. Thank you.